Hello, welcome to everybody. This to the HemaTalk number 3 about acute myeloid leukemia. And today we will have the opportunity to listen for very famous and very good hematologist, Professor Giuseppe D'Onofrio from Rome and Professor Gina Zini from Rome too. They are experts in hematology. They have contributed a lot in the European School of Hematology, and we are honored to have them in this attending this meeting. As you can see here, he is a professor in the clinical in the Catholic University of Rome. Acute myeloid leukemia has been changed a lot in the last years due to the recurrent cytogenetic abnormalities. Today, we have now not general chemotherapies, but therapies related to address the fusion gene or the oncogene that produce the leukemia. Today, to have a translocation 821 or a translocation 1517 RARA is really changing the whole prognostic, because you have a good prognosis. Also, when you have the inversion of the chromosome 16, and today we have to try to find that, to try to find which are the molecular aspects of this leukemia, if it's GATA1 positive or not, in the case of myeloid leukemia related to Down syndrome, etc. For this reason, there has changed the molecular and cytogenetic, the whole picture in acute myeloid leukemia. Let me share my screen now, okay? And here we are going to, we are waiting for Professor D'Onofrio to be in the meeting. Let me see if he's now here. Not yet, but we are going to wait for them.
Ramon?
Tell me.
Hi, Ramon. Yes, I think that to avoid to waste time, if you wish to introduce myself, I can start with the presentation, and then Giuseppe will join the meeting.
Absolutely, Professor Gini. It will be a pleasure to introduce you and to introduce your speech. Let me see. Yes, let me introduce Professor Gina Zini. She's an associate professor of oncology and hematology in the University of Cattolica del Sacro Cuore in Rome, Italy. She's a board member of International Society of Laboratory Hematology, ISLH. She has led many of the initiatives and many of the new standards. It's famous that everybody is using, for example, the definition and the guidelines for the schistocytes. When we found the schistocyte first, what is a schistocyte, how to confirm it, or how to help to confirm that they are really schistocytes with the presence of spherocytes, etc. And that was very helpful for all the hematologists in the world. She's scientific secretary of the International Committee for Standardization in Hematology, ICSH. He is member of the WHO Technical Committee, and his specialty is hematology diagnostics, morphology, hematology laboratory. I have to say that in the world there are few very good morphologists, and she is one of them. Welcome, Professor Gina Zini. Now you have the floor.
Thank you. I'm going to share my screen.
Yes, please.
Yes, I did it. So I start with this speech on morphology in acute leukemia. And this is the definition according to the WHO. Acute myeloid leukemia is a clonal expansion of myeloid blasts in peripheral blood and bone marrow or in other tissues. From a point of view of the clinical features, this disease are very heterogeneous, and are heterogeneous not only for clinical output, but at diagnosis for genetic variations and for some morphological defined aspects. And AML can involve one or all the myeloid lineages. The epidemiology, according to the WHO data. In adults, the worldwide incidence is 2.53 cases per year, higher rates in Australia and Western Europe, with the median age at the onset of 65 years, with a slight male predominance in most countries. While in children less than 15 years, EAM constitutes up to 20% of all cases of acute leukemias, with a peak incidence in the first 3-4 years of life. I'm used to start with the principle of the WHO classification that it's worldwide adopted, and the principles are based on the consensus. So the is to provide a consensus classification using all available information that are morphology, cytochemistry, immunophenotype, genetics, and clinical features. And all this multifaceted approach to diagnosis led to definition of clinically significant disease entities. The idea is to provide a classification that can be used in the daily clinical practice, and that can serve as a common language for clinical trials and laboratory investigation. Third, myeloid nomenclature is fundamental to agree on several contexts not only in hematology but in the scientific fields. So with the term myeloid, we include all cells belonging to the granulocytic, monocytic, macrophage, erythroid, megakaryocyte, and mast cell lineages. And we are talking exactly of these acute myeloid leukemias. By definition, except for rare cases that we will see, blast percentage is conditio sine qua non, and it's needed an amount of blasts as 20 or more % in peripheral blood and in bone marrow. Blast percentage and on peripheral blood and bone marrow remains fundamental also to evaluate disease progression, so for the follow-up of our patients. In the last edition of the WHO classification, there are exactly these subgroups, and we will go through each of these groups, mainly highlighting the morphological aspects that can predict the final diagnosis. And here we are to underline that morphology still remains, after the instrumental report, the first approach in the diagnostic pathway. And we will see that some morphological features are peculiar and can predict also the genetic lesion of the acute leukemia. On the right side of the screen, you see the classification of the WHO on the year 2008. The new one, that is the revised classification, in the context of the acute leukemias, did very few changes, but very important. The first one is on nomenclature. Acute promyelocytic leukemia is now defined as APL with PML rara gene mutation, and this is due to the relevance that the presence of this mutation has in the diagnosis, the follow-up, and the prognosis of APL. Here we have changed in the nomenclature of the genes, and another change is that the introduction of cases that with the BCR-ABL1 abnormalities at the onset, so de novo cases. Again, here it was needed to include this subgroup due to the improved prognosis of this subset of patients, while it's important to be able to make this diagnosis for these patients with the RAS1 mutation, because the impact on the prognosis is very bad. And finally, you know that the pure erythroid leukemia that in the 2008 classification was included in the acute myeloid leukemia, now has moved to the as a subgroup of MDS. So we can start with the entities. The first subgroup are acute myeloid leukemia with recurrent genetic abnormalities. Among these, the first three that are acute myeloid leukemia with Ep.3 translocation and PMLRR and 16/16 translocation are defined as a leukemia regardless of the blast count. This means that we see blast in peripheral blood, we see the morphology, we can predict the presence of each of these three mutations because the morphological are very peculiar, and we can conclude as AML also if the blast count is less than 20%. Moving to the first one, AML with 80-21 translocation has a very peculiar morphological pattern. There is presence of variable dysplasia, usually that involves the granulocytic series. Eosinophils may be involved, but are normal, are not clonal. And usually monocytic component is minimal or absent. The morphology of blast is very, very peculiar. Blasts are very large in size, abundant basophilic cytoplasm, a very relevant perinuclear HOF because it's a leukemia with a differentiation. And in the cytoplasm, there are several azurophilic granules, sometimes with big granules due to the coalescent of the smallest granules. And the name is pseudo-celiac Higashi granules. And frequently, a blast do include in the cytoplasm a single elongated or needle-shaped outer rod. Also, the immunophenotype is peculiar, and again, there are some CD expression that can correlate with an adverse prognosis. And here we see the blast. Large blast, you see, with abundant cytoplasm, blast with immature chromatin nucleoli, and in some blasts, the presence of a very thin needle-shaped outer rods. Again, another images, you see another group of large blasts, sometimes with monocytic nuclear features, with indented nucleus, again, immature chromatin, basophil cytoplasm, more than one nucleoli, blast with single long-shaped outer rod. This is an image on the right of myeloperoxidase stain, and you see, for instance, that in this blast, the outer rod is on the nucleus. And it's very important always to go on with the myeloperoxidase because sometimes at Megrun-Manginsa, we are not able to highlight these outer rods that are so peculiar that can predict the presence of this translocation. So a morphology that is highly predictive of the 821 translocation. The second leukemia included in the group of the AML with a cytogenetic abnormality is the group of AML with inversion 16 or translocation 16. Also here we have a morphological pattern quite specific because blasts are mainly for myelomonocytic leukemia, and there are an abnormal eosinophil compound, are always more than 5% in bone marrow with normal maturation. And we have, in the previous subgroup, eosinophils were not part of the clone, of the blastic clone, while in this subgroup of leukemia, having this translocation of the genetic abnormalities, the eosinophil compound is a part of, is clonal, and we can appreciate with the cytochemistry that usually the eosinophil granules in non-eosinophils are myeloperoxidase positive, while the clonal compound, eosinophilic compound, show positivity to the naphthol chloroacetate esterase reaction. The immunophenotype is complex with the presence of multiple blast population, and we have a subgroup of immature blasts as well, a group of population with differentiation towards or granulocytic or monocytic lineage. And here we have images. You see that we have, this is a pro-eosinophil, so this is a promyelocyte with eosinophil granules. This is a blast, and this is another big blast with the immature chromatin with the shape of a monocyte. Another case showing picture from other, these are pictures from different patients. You see here another big blast with a nuclear shape like as a monocytic lineage. You see eosinophil with these blue dark granules that are the pro-eosinophil granules. Again, another myelocyte with eosinophilic granules. And this is the double reaction to peroxidase and the chloroacetate esterase. And you see that these are below, but this is an eosinophil on peripheral blood. Those two eosinophils are clonal and are positive to the chloroacetate esterase, while this one, and this is another one, are normal eosinophil. So images like this with blast and eosinophil compound are strongly predictive for presence of these genetic abnormalities. The third subgroups of myeloid leukemia with recurrent genetic abnormalities that are considered AML regardless blast count is acute myeloid leukemia with the PMPAR fusion gene. The morphology here is fundamental, it is important because this is one of the rare cases of hematologic neoplasm that are really some emergency. So we should identify immediately the blast cells, promyelocytes, to promptly administer the retinoic acid to induce differentiation of a blast that could save the life to the patients. The morphological pattern includes the group of hypergranular pomyelocyte that is named morphologically typical, irregular nuclear size and shape with the cytoplasm densely packed with the coalescent large granules, strong myeloperoxidase positivities, and most of the cells do show bundles of our roots. And the other morphological features is the hypogranular And blast, promyelocyte in this case, they do have a bilobed nuclear shape, and at Megrumba-Gimson it seems that there is a paucity or absence of granules because are very, very small, and they do so at Megrumba-Gimson we can not be able to appreciate granules, while with the cytochemistry, these granules are highly strongly positive to the myeloperoxidase. Immunophenotype 2 is very typical with negativity of HLR and CD34, and again there are CD that are associated with a worse outcome. And here we have a morphology. These are pathological pomyelocytes, hypergranulars. These cells show a lot of our rods inside, and you see how dense, how marked is the myeloperoxidase positivity. And here another blast with several our rods. In these cells, we see that this is an acute myeloid leukemia with a tendency of maturation. So it's not unusual to find more mature form clonal showing the our rods. And these are, this was from a case, look at this is a mitosis with our rods. And this is are images from cerebrospinal fluid for localization of an APR. Here we have the images of the morphological variant hypogranular. And this morphology is very, very typical, but we have to think this and not to miss this morphological identification. Nuclei are show bilobed shape, and you see that the granules seems to be inconsistent in some blasts. Look at this and this, but they are strongly positive to the myeloperoxidase. We have also some molecular variants that are related to other morphology. There is the variant Ep.3 where associated with hypergranular promyelocyte. This is a molecular variant. This is another molecular variant, and is quite characteristic, and it's very, very important to suspect that the diagnosis, because in these variants, genetic variants, there is a predominance of hypergranular promyelocytes, strong myeloperoxidase activity, but absence of other root. So this genetic subtype is not sensitive to the maturation ATRA-induced. So it's very important to suspect this because the patient should be immediately treated in not by using ATRA, but by using other standard therapy. But we have a warning, a very important warning, because there are some acute myeloid leukemia with an NPM1 mutation that are in which blasts are hypergranular blasts, promyelocyte-like, strong myeloperoxidase, no our rods. So the take-home message is that it's very easy to make diagnosis of hypergranular promyelocyte with our rods. Think about in cases of hypergranular blast without our rod, check if this is a case that is resistant to ATRA, or if it is not a promyelocytic leukemia, again also this resistant to ATRA. In the clinical practical use, because this is really an emergency and sometimes the molecular and genetic results do show a delay, usually these patients are immediately treated with data and immediately checked to perform the right and correct diagnosis. In the first group of AML with recurrent genetic abnormalities, there are other subtypes, again with a morphology that could be predicted. This is an acute AML with a 9/11 translocation. Starting from this subgroup, for the diagnosis of the AML, the blast count should be 20% or more. The morphological pattern show monocytic features, and in the blast count, we should include the monoblast and the promonocytes. I remember this is from the papers, the old paper that from the MDS morphology group, and here are clearly highlighted the morphological features in the monocytic cells. Monoblast and promonocyte should be measured in the final blast count because promonocyte should be considered a blast equivalent in presence of a monocytic lineage expansion. At the microscope, we see that the difference among monoblast and promonocyte is the shape of the nucleus. So this is so the chromatin pattern does represent the morphological key to define these two monoblast and promonocyte that should be included in the total blast count, and to make a difference from immature monocytic cells. These cells, immature monocytes, should not be included in the blast count. In children and adults, there are different immunophenotype, and these are the images from morphology. So we have irregular nucleus, these are promonocytes, these are monoblasts. You see how is predominant and homogeneous the morphological pattern. Again, we have a monoblast and we have a promonocyte. Monocytic lineage are positive to the naphthyl esterase. So again, cytochemistry is very useful to identify the monocytic lineage and the blast, and to be sure that are monoblast or promonocyte. And the subgroup of the translocation 2% or more in peripheral blood and the bone marrow. The morphological pattern, except for the promyelocytic leukemia and the megaloblastic, can blast the shape of granulocytic, monocytic lineage. There is no one specific myeloid immunophenotype. Again, it's very, very important to go on with the cytochemistry. This is the toluidine blue that clearly identify the basophilic lineage that is always expanded in cases with this translocation and this DECNAP 214 gene abnormality. And the other AML with genetic abnormalities is AML with inversion 3 and resulting in deregulated MECOM and the GETA2 expression. Blast count is needed 20% or more, any subtype other than APL, but characteristically in this subgroup of AML, there are dysplasia mainly referred to the megakaryocytic lineage. So megaloblastic features are the most common with dysplasia of platelet, but dysplasia can be observed also in the neutrophils, in the granulocytic lineage. While myelofibrosis is variable, this is notable because we are used to consider increase of fibrosis in all the clonal expansion of megakaryocyte. This is the immunophenotype more frequent of blasts of this AML, and with some variability among cases. And we have another AML with translocation 122 with this gene abnormality and megakaryocyte 1. And this is in infants, mainly in young children, lacking transmission. You see that is an expansion of megakaryoblast, myelofibrosis always present, and we had the features of acute megakaryblastic leukemia not otherwise specified, and blasts are medium to large sounds, irregular nucleus, nucleoli, basophilic cytoplasm, and they are negative to myeloperoxidase, esterase, so the final identification should be done by using the immunophenotype. We can suspect, can define this blast as a megakaryoblast only by using the immunophenotype. And there is de novo, there are one new provisional entity in the last classification, that is the group of AML, the novo AML with BCR-ABL1 gene alteration modification. Cases are rare. This one is images from CML with the positivity of BCR-ABL1. This should be considered de novo axis of chronic myeloid leukemia. There are less common dwarf megakaryocyte that are these nanomegakaryocyte that is a morphology very typical in CML, and this morphology, this dysmorphic morphology is. And we mentioned this in talking about APL. There are a group of AML with gene mutation. This is nucleophosphate-1 mutation, and this is important because it could show from a morphological monocytic or hypergranular polymonocyte-like blast features. And the of or an history of MDS or MDS-MPN disease, or the myelodysplasia-related cytogenetic abnormality, or presence of lineage dysplasia in at least 50% of the cells in at least 2 lineages. And this patient should not have mutation of NPM1, neither CAPB. On the left, you see the morphological features that should be considered as dysplastic in the erythroid, granulocytic, and megakaryocytic lineage. While on the right, you see the list of genetic abnormalities that are considered myelodysplasia-related genetic abnormalities. So The diagnostic criteria, again, blast plus or one history, or one of these alteration, or dysplasia in at least 50% of the cells in at least 2 lineage. And this is our images where we see dysplasia of erythroid cells, dysplasia of granulocytic cells, and dysplasia multinucleated megakaryocytic cells, together with blast. You see blast with our rod here, blast undifferentiated. So blast number and evaluation of dysplasia. At least 50%. This makes the difference from the diagnosis of MDS, where the percentage of dysplasia should be 10%. The third group are the therapy-related myeloid neoplasm. This group includes different leukemias that are a unique clinical syndrome that is distinguished by prior iatrogenic exposure to mutagenic agents. They do represent up to 20% of AML, MDS, MDS, MPN. And this is a group of leukemia with a poor prognosis. Thanks to the improvement of the resolution of the first cancers, this number of leukemia are increasing because as a second cancer in individual that have faced the first one. This is the definition. Therapy-related include AML, therapy-related MDS, and MDS-MPN. This means that 20% of blasts cannot be present because the anamnesis of this patient is fundamental for the definition of this leukemia. Mostly presenting with cytopenia, dysplasia, basophilia, and a number of these cases shown to have germline mutation in cancers susceptible to gene. You know that now with the gene profiling and next generation sequencing, we have highlighted a group of genes that can predispose the individual to the development of cancer. And this is a case that is therapy related in a patient that she was treated for rheumatoid arthritis with azathioprine. And after 5 years, she presented in peripheral blood with disease dysplastic pseudopelvic neutrophils and a blast with an hour roots. And this was a therapy-related leukemia. Look at this young megakaryocyte with a big cytoplasm with dysplastic maturation of platelet. You see blast positive to myeloperoxidase with our rod and dysplasia in erythroid series. So this was the picture of our patients. The fourth group of subgroup of acute leukemia are called acute myeloid leukemia NOS, not otherwise specified. This group is very heterogeneous and accounts up to 30% of all the acute myeloid cases. And the diagnosis is based on the presence of blast count 20% or more and the classification according to morphology, cytochemistry, and immunophenotyping. So I strongly underline the WHO recommendation that discourage the use of the FAB classification. But, and for this, the subgroups that are included in this group of NOS, acute myeloid leukemia NOS, are the myeloid leukemia with minimal differentiation, undifferentiated blast, negative to the myeloperoxidase, so the diagnosis should be performed by flow. And the second group is AML without maturation, undifferentiated blast, but scattering a few granules were evident at myeloperoxidase. And again, we have as a third group AML with a maturation. This means that up of 25% of blasts are promyelocyte on myelocyte with percentage of neutrophils bound form. Again, these blasts are positive to the myeloperoxidase. The other group is the acute myelomonocytic leukemia. From a morphological point of view, we have blasts that are negative to the myeloperoxidase, positive to the acetate, naphthyl acetate esterase, and with the features of the or monoblast or promonocyte. Then we have the subgroup of acute monoblastic leukemia. Blasts are monoblasts, giant cells with porous cytoplasm, sometimes scattering backwards, with usually round or slightly indented nucleus, positive to the alpha naphthyl acetate esterase. While the differentiated form of the monocytic lineage is the acute monocytic leukemia, where we see a lot of immature monocytes. So for this definition, we need 20% of, at least 20% of monoblast and promonocyte, and together with a differentiation with the immature form towards the more mature form of the monocytic lineage. And then we have the acute megakardioblastic leukemia. By definition, morphology is the same of the form associated with this gene abnormalities. So the definition, this is a diagnosis based on the exclusion of the presence of these genetic abnormalities. Again, blast count should be 20%, and 50% of the 20% of blasts should be of the megakaryocytic lineage. Again, obviously, here we see platelet dysmorphic, giant, abnormal, and megakaryocyte. But the definition of this blast, we can clearly suspect the megakaryocytic lineage, but only by using the flow we can perform the final diagnosis. So this is an acute megaloblastic leukemia because these blasts are megakaryocytic lineage and this patient lack these abnormalities. And the other form is the acute basophilic leukemia. Important to read in blue to identify the positivity. And the other cause is the acute panmyelosis with the myelofibrosis. Usually the diagnosis, this is a very bad prognosis, and the diagnosis is performed with a bone marrow biopsy because the bone marrow aspirate is trap. And here we see images of the particles showing this fibrotic, and so it's quite characteristic, but it's quite unusual to have material on bone marrow aspirate in patients with myelofibrosis. The first subgroup includes the myeloid sarcoma. By definition, this previously was known as granulocytic sarcoma or chloroma. This is the localization of an extramedullary proliferation of blasts in one or more of the myeloid lineages that disrupts normal architecture in the tissue in which it was found. This is a very, you see, these are the blasts positive at myeloperoxidase. This is a needle aspiration of a lymph node. And this is what was very interesting because these patients showed on the left of the iliac bone marrow aspirate normal bone marrow. And the localization was only on the right of the iliac sphenic bone. And this is something that we have to take in our mind because chloroma is localized, so it's possible to have a bone marrow normal and the contralateral is a bone marrow with the infiltration. And here we are with the subgroup number 6 that are myeloid proliferation related to Down syndrome. And there are two subentities. One are the TAM that are transient abnormal myelopoiesis in subject with children with having Down syndrome, and the prognosis is very good. While the other subgroup are MDS and AML, Down syndrome related, and this the prognosis depends on the age, depends to the presence or not of the GATA1 mutation. These are images of a baby and in our that we faced in the children department, and you see the peripheral blood showing this blast, and this was the bone marrow, and you see the presence of high rate of mitosis, blast, and some dysmorphic features. Well, this was the last slide. I am obviously ready for questions, if any. So I stop to share my screen, and I leave the screen to Professor Donofrio that can chair the other part of this HemaTalk. Thank you.
So hello everybody. I'm very sorry for having missed the beginning of the meeting. I had prepared tonight, working in the night, a very nice introduction, but I see that the time has run, so I just want to see if there are questions for Gina. Now it's time to ask her questions. There was one question. Let me check if I can. You can see this. Okay.
Professor Gina, it's possible to find blasts in peripheral blood and bone marrow, but with no CD detector. Yes,
No,
this
yes,
is possible.
well.
This,
to Professor
yes.
Gina, I read the question. The question is from Putri Chadija. Sorry for pronunciation. Gina, is it possible to find blasts in peripheral blood and bone marrow, but with no CD34 detected or DIM from immunophenotype examination?
Yes, this is thank you for this question. That is very, that highlights a very critical point, because the WHO classification is the blast count is based on the morphology, and we know that there are some morphological cells with blast appearance that are CD34 negative, while on the contrary, there are cells that are CD34 positive that do not show the blastic appearance, blastic criteria. This is something that is still running, and so the answer is yes, is possible. The key point is how people usually in the lab do provide the blast percentage, because just speaking in Italy, there are some centers they do not have good morphology, so they use the blast count provided from the flow, and this can lead to certification of the diagnosis in patients, because the approach of flow is more numbers and CD34 positive. But this is the real life. On the other side, there are some centers that they do not perform. I speak just centers that I know in Italy, that they do not perform the bone marrow aspirate, but only the bone marrow biopsy. So again, blast count is semi-quantitative, and sometimes by using also immunochemistry. So it's by sure that there are discrepancies between the morphological blast count and the flow and histological blast count. That's life. We have to combine these real life diagnostic approaches.
We have another question now from the same Dr. Putri from Indonesia. Gina, should we perform cytospin CSF to find blasts for all cases of AML, or is there any indication to do so?
Well, we do this under clinical request. There is, but for but for lymphoid diseases and for promyelocyte, we should think. But our clinician send us, so it's something that we have to work in advance against the cancer. So we know that there are a list of clonal disease that can be go to the central nervous. So we have to evaluate in advance. In children, in adults with lymphoid, in promyelocytic, we have two things. And in those cases that are negative, they do have a lymphoma on the brain. So this is up to clinician, but, because we work in the lab, but we see a lot of spin of from cerebrospinal.
We have one comment from Sahel Ahmed. The comment is, chromatic remodeling is thus connected to the monocytic features. Is a question or a comment, I don't know, but what do
the point is that the chromatin remodeling is something that pertains to genetics, to molecular, to genes, is not applicable to the morphology at optical microscope. If instead of remodeling, we use the terms chromatin pattern, that means in the monocytic lineage it is a very fine reticulated pattern. So if you mean this, yes.
We have one more. Dina Merita is asking how we can diagnose a myeloid sarcoma, because it's need of a needle biopsy, and how is the clinical symptom of this disease?
I can. We have very few cases, and one of these, the slide I showed you, and it was very difficult cases because it was clear that the patient had a cancer, but she was a female. She performed the bone marrow aspirate on the left. And the bone marrow aspirate was normal, without blast, maybe hypocellular, but quite normal. After looking for the cancer, it was repeated on the other side. And the images were not from aspiration, because it was a needle aspiration for biopsy, but was for apposition of the needle aspiration. And this was the key for the final diagnosis. So these cases are rare, but again, we have to think about this, especially when we don't find the original cancer.
Well, we have maybe two questions. I will put them together from Putri Chadia again and Abhishek Sharma. Because Putri asks if it is better to determine blast count with morphology or by flow cytometry. And Abhishek asks if it's better myeloperoxidase detection by cytochemistry, immunohistochemistry, or flow. So these are complementary questions. A short
I don't know.
short
I don't
answer.
know what is. I can answer is better or no. I have illustrated in the presentation the rules. So the rules is blast count at morphology, at optical microscope. Obviously, if I have an hypocellular bone marrow aspirate, I use all the things that I have, biopsy, flow, immunochemistry. But on the other side, we know that not all labs are able to provide a morphological blast count. So I don't want to say it's better or worse. The things that I say is that there are rules. So if I have 5%, 7% of blast, I am stratified in a better prognosis subgroup of MDS. If I say 9%, 10% of blast, the patient is stratified in a worse prognosis subgroup. So this is everywhere in international groups we discuss this, but I am afraid that at the end of the story, the molecular genetics will be the winner, and we will not use microscope and flow, but gene profiling and so on. In this moment, we have the rule, because you have the WHO rules, and we have the real practice that can differ among various groups. But just to inform you that all the clinical trial, there is a centralization of the revision for the morphology. And this is needed exactly because blast count is performed in different lab in different way.
This is not the short answer I had asked for, but there is
Okay.
very last one. This is the very last one that we need a very quick reply. Agus from Indonesia asked if there is a discrepancy between marrow biopsy and aspiration, and which one is the gold standard for the diagnosis. That's really
the diagnosis again the same as the bone marrow aspirate. This discrepancy is normal because the blast count at biopsy is semi-quantitative, but on a lot of cells. Blast count in bone marrow aspirate is out of 500 cells, and is singly detected cell by cell. So discrepancy is normal.
Okay.
But the WHO speak of blast count for bone marrow aspirate.
So I think that we had a lot of greetings and congratulations for this presentation.
Yeah, Professor Gini, I have a question for you.
Okay.
I have attended a conference of Professor Thorsten Haffler, and he said that in the future, not now, because now it's clear that the WHO set the rules very clear, but in the future, we will only need to know if it's acute myeloid leukemia or lymphoblastic, and all the rest will be next generation sequencing. What is your opinion about the role in the future of next generation sequencing?
It's exactly what I told in advance. In the next features, we will not need a microscope. But the key point is that the world is populated by rich countries and poor countries. So I think that we have to maintain the expertise for the less developed countries, because the blast count at the microscope is the only possibility to make a diagnosis. But the future only in this classification, we have now subgroup of acute leukemia that are irrespective if myeloid or lymphoid, but are defined by the presence of platelet-derived growth factor abnormalities and not. So we are already in the future. It's a question of costs, but this is the way for the future.
Thank you so much.
In my opinion.
Very nice presentation. Thank you.
Okay, now it's time for the award announcement. I thank you very much. There were a few more questions. Maybe during the awarded case presentation, we can go back because someone was asking about biphenotypic, someone was asking about promyelocytic. So we have such cases. So I can invite, I stop to share my screen and stop share. And I'm inviting Dr. Putri Tampubalon from University Hospital of Medan, Indonesia, for a talk about his clinical case, which is a myeloid leukemia associated with Down syndrome. Please, Dr. Putri.
Thank you, Prof. I'll start share my screen.
Yes.
Greeting from Indonesia. My gratitude for Prof. Giuseppe, Prof. Gina, and Prof. Ramon. And thank you for Mandre and team for giving me this opportunity to join this event. I am Putri and I am from Indonesia. Today I want to share an interesting case about myeloid leukemia associated with Down syndrome. We know that Down syndrome patients have an increased risk of acute leukemia, and with this case, I have a 2-year-old girl with Down syndrome phenotype, with mongoloid slant of eyes, flat facial features, protruding tongue, and short broad hands. Without familial medical history of malignancy, presented with 7 days consisting fever and being pallor, gum bleeding and black stool since 1 day before hospitalization. This patient was the third child of healthy unrelated parents. The mother and the father were at birth of the child 36 and 32 years old respectively. Also, there was no infection in the pregnant woman during the pregnancy, and she was born by normal vaginal delivery to the 32-year-old multigravida at 30 weeks of gestation with a birth weight of 2.9 kilograms. Antenatal and perinatal periods were uneventful. From the laboratory result from cell morphologies, this is the peripheral blood film. We found 3 myeloblasts with high nuclear to cytoplasmic ratio, granular cells with nucleoli presence. There is also myeloblasts with moderately basophilic cytoplasm. And another myeloblast, we see that the red cell blood and the platelet is low. We've done this with GIMSA staining. And this is the cell morphology from the bone aspiration, the bone marrow aspiration. We found elevated myeloblasts with high nucleocystoplasmic ratio, with rounded nuclei, with immature and dispersed chromatin with 1 or more prominent nucleoli. We found elevated myeloblasts with less than 10% of maturing cells of granulocyte or monocytic lineage. This is the automatic blood counter. We found the hemoglobin is at 9.0 and the white blood cell is elevated with 16,000. We also found the low platelet at 32,000. We also perform flow stoichiometry in this patient. We use CD45 to gating the population of leukocyte cells alongside with the site scatter. The red is the blast population. We see that the site scatter is low and the CD45 is dim. So this is the blast population. And then we found the cell population, the blast population is CD36 and CD30 T bright. And we also performed the cytogenetic with FISH, fluorescent in situ hybridization with a specific prop for 21. We found the trisomy 21. Another laboratory result is we performed liver function test and we found elevated total bilirubin and elevated direct bilirubin. And we also found elevated ferritin, and another lab is in normal range. So the diagnosis from the WHO 2016 is the myeloid leukemia associated with Down syndrome. The laboratory tests reveal anemia, leukocytosis, low platelet, and abnormal liver function. Cell smear indicated significantly increased myeloblasts that positive for CD45 dim, CD34, CD7, CD13 dim, CD33, HLA-DR, CD36, and CD117. FISH show trisomy 21. The patient failed to achieve remission after chemotherapy. That this showed a poor prognosis of the myeloid leukemia associated with Down syndrome (MLDS). Thank you. I'm sorry, Prof. I think you're still on mute.
Sorry, thank you very much.
Yes.
This case was awarded as an uncommon case, and Professor Ramon Simon Lopez can comment, give his comment, and also stimulate questions.
Yes, AML related to Down syndrome is really a very dramatic situation because these children are very sensitive to the chemotherapy. Really, the cytotoxicity is higher because the Down syndrome. And even if there are some nice studies about the chemotherapy with the Berlin, Frankfurt, Munster protocol in the 98, they have problems with this and they have poor prognosis because that they had received very bad the cyto reduction with chemotherapy. I congratulate you for this very nice case. Really was very well presented and very well documented, and really you deserve this prize. After we will introduce some questions after your presentation about if you have performed or not the GATA1 test, the presence of GATA1 in this case. But okay, thank you so much.
Thank you, Prof. Ramon, for your comment. Yes, we know that the GATA1 mutation is associated with this disease, but unfortunately, we did not perform the examination. So we cannot conclude that if the mutation GATA is associated with this disease, but from the studies, we know that the GATA1 mutation is correlated with the myeloid leukemia in Down syndrome. Thank you, Prof.
Thank you so much. Thank you.
So this was a very interesting case, and we proceed with the new speaker, the new awarded case, and this was awarded as a classical case, the most classical case among those who received an award. And after the case, I will ask Gina Zini to comment. I stop my screen, and Dr. Cosita Proco from Castelfranco Veneto, Italy, will show and illustrate this case. Can you share your screen?
Hello to everyone. Am I sharing my screen with you? Because I have some... Can you hear me?
Here, yes. But the screen is not sharing.
Am I sharing the screen with you?
Yeah.
Is it okay with this?
No.
Okay. we see now.
Okay. Is it okay? Am I sharing
Perfect.
the screen with you?
Yes.
Okay. Okay. Hello to everyone. Thank you for this wonderful meeting. I would like to thank the organizers, and I would like especially to thank Dr. Zini for the wonderful information and the time that she's sharing with us today. My name is Giuseppe Procco. I'm glad that this classic case of an acute promyelocytic leukemia has been selected for this contest. The acute promyelocytic leukemia is a subtype of the acute myeloid leukemia. It represents from 5 to 8% of all the AMLs with distinctive biological, morphological, and clinical manifestations. The disease is characterized by the proliferation of a malignant group of promyelocytes, which we can find both in peripheral blood and bone marrow. A chromosomal translocation is known to be the cause of the clinical manifestations. It includes the retinoic acid receptor alpha on chromosome 17, the gene on chromosome 17q12, and the promyelocytic leukemia gene on chromosome 15q22. First, the acute promyelocytic leukemia was described as a fatal disease with a survival time less than a week. But today, the prognosis has drastically improved, and it's a highly curable disease only if it has an early diagnosis and started therapy. So it's considered to be an hematological emergency. This is the clinical case of a 46-year-old man who this summer went to his primary care physician for presenting bruisings all over the body and gingival bleeding. So the physician prescribed to him some first laboratory exams. The clinical history of this young man showed no familiarity for blood cancer diseases. Usually what we do on our routine work on the laboratory, when we find abnormalities on the complete blood count, we go further with preparing the peripheral blood smears with gemcitabine and the observation on the microscope of the peripheral blood of this patient showed a high percentage of immature cells. The left two images right here are obtained with the help of a digital cell morphology system. And what we clearly see right here is the presence of two promyelocytes. The promyelocytes in the hematopoiesis on the myeloid lineage follow the myeloblasts and lead then after maturation to the myelocytes. They measure from 12 to 20 micron on diameter, and the characteristic, the morphological characteristic of these cells are the nuclei. It's quite the same size of that of the myeloblasts, but they have a more abundant cytoplasm. Also, the nuclei shape, usually it is round or oval, but it can also be, like in this third image here, a dumbbell-shaped nuclei. The most important morphological characteristics are presented on the cytoplasm. We have a hypergranulated cytoplasm with the presence of an abundant azurophilic granulae, which give to these cells high strong myeloperoxidases. The primary granulae may be also incorporated in our rods, which can also be stacked in bundles of what we called the fagot cells. So the clinical symptoms of this patient and also these peripheral blood images has given to us more than just a suspicion for the presence of an APL. So what we have done, we have called the patient and we invited him to immediately enter the emergency room, where the physical exam confirmed the presence of multiple bruisings, thorax and abdominal ecchymosis, and gingival bleeding. An important exam was the cranial CT scan, which showed the presence of a left frontoparietal hemorrhagic foci. He had good vital signs, though. These are some more laboratory results. What we see are a light increase of erythrocyte sedimentation rate and a lactate dehydrogenases. But what's important to observe right here is low level of fibrinogeno. And as we will further on see, we have a low platelet count. These two parameters are very important for monitoring these patients, and they are to be performed and determined every 6 hours in these patients. Because what we see, the most notorious manifestation on the APL disease is the life-threatening coagulopathy with both presence of bleeding and thrombotic events. This is due to the promyelocytes, which can express two associated procoagulants, which are the tissue factor and the cancer procoagulant. In the majority cases, we can find prothrombin time and partial thromboplastin time, which are elevated. But there can be also cases like this one, where these two parameters are normal, but this cannot exclude the presence of an subclinical disseminated intravascular disease. These are two images of the bone marrow, bone marrow aspirate, which shows, highlighted here, an hyperplastic bone marrow, abundant in the presence of promyelocytes, which normally in a normal bone marrow have to be around of 3% on a normal bone marrow. Finally, this is the complete blood counting of this patient. As we can see, he had a severe thrombocytopenia, anemia, and neutropenia. The flow cytometry in the white blood cell differentiation channel shows right here a poor separation of two clusters, the neutrophil and the monocyte clusters. It seems like there is a unique cluster of an abnormal cell population where the promyelocytes are plotted. The molecular test report confirmed the presence of the chromosomal translocation of the retinoic acid receptor alpha on chromosome 17q12 and the promyelocytic leukemia gene on chromosome 15q22. The hybrid PML-RARA gene is responsible for the arrest of the differentiation of the promyelocytes, because the PML protein has a very important role on the control, in charge to control the apoptosis of these cells. So this is the immunophenotype, both in bone marrow and in the peripheral blood. And it is characterized by the presence of a CD13, CD33, CD45, and CD117 with a lack of HLA-DR and CD34. So we have a completed diagnosis of an acute promyelocytic leukemia. This is a classic form of an acute promyelocytic leukemia, the hypergranulated with a translocation PML-RARA. when we arrived at the complete diagnosis, the patient was already sent to the intensive care unit, and the therapy with all trans-retinoic acid was started, combined also with arsenic thyroxide, which led that to the apoptosis of the differentiation cells. At the previous classification of the French, American, British classification, the APL was included on the acute myeloid leukemia type M3, but the new WHO classification of 2016 classified this disease as an APL with PML rara. So the take-home message from this presentation and which I would like to highlight is the very important role of the laboratories to early diagnose an acute promyelocytic leukemia, which can save lives of the APL patients. Thank you for the attention.
Thank you very much, Dr. Proko. And I want to let you know that you have had more than 520 people listening from you from all over the world. Now, a comment from Professor Gina.
Beautiful cases were presented and completed. Just to underline that in recent papers of 2 years ago, it was noted that up to 20% of APL patients worldwide presented at emergency were not correctly diagnosed. And this is very, very sad because this is really an emergency. And so the ability of the lab to immediately provide a suspect of the APL and to give the vitamin, because at the end the other is like a vitamin, can save life. So thank you for this case, Dr. Proko.
Thank you, Dr. Gina.
Thank you very much for this case, the classical one. And then we can go ahead for the next award announcement. And this is Dr. Bahong Yu, and from the Zhengzhou University in China. It's an interesting case of acute myeloid leukemia with minimal differentiation. Please go ahead.
叶老师，您可以开始了。
Hello everyone，非常高兴有这个机会与全世界的专家学者一块探讨急性髓系白血病的问题。
So today I'm very glad to have this opportunity to discuss with all the experts from the world something about AML.
我今天给大家展示的病例呢是 AML with minimal differentiation.
So today my case is the AML with minimal differentiation.
下面我介绍病例的病史。
This is the medical history.
患者女性，65岁，因发热中性粒细胞减少1个月就诊。
So this is a 65-year-old female patient who was treated at the local hospital due to a fever and granulocytopenia for more than 1 month.
曾使用中成药地域生白片治疗，但效果不明显。
So she was treated previously with the Chinese herb tablets, but wasn't effective.
白细胞在2.0乘10的9次方。
And you can see that white blood cell count 2.09 times the 10 to the 9th.
中性粒细胞百分比在20%，绝对值在0.27乘10的9次方。
And for the neutrophil, we have 20% of the percentage, and the absolute value is 0.27 times the 10 to the 9th.
后住院进行治疗。
And then the patient was admitted to our hospital for further treatment.
在这个患者的骨髓图片上，我们可以看到他的细胞中等大小和质比比较大， 染色质非常细致，核仁明显。
So from this particular laboratory result, we can see that the size is of medium to large, and also the nucleoli is very clear, and also the chromatin is very fine.
这是它的细胞化学染色的结果。
And the second picture showed the result of the chemical dyeing and the staining.
最左边是过氧化物酶呈阴性反应。
So on the further left, we have the negative reaction of the perioxidase.
中间这两幅呢是非特性脂酶染色呈点状阳性，但是氟化钠抑制试验没有抑制。
And also we can see that the two images in the middle show that we have the non-specific esterase staining with the dotted staining here, but with no specificity.
最右侧是糖原染色呈阴性反应。
And also on the further right, we can have the PAS staining with negative reaction.
这是它的血象检查结果，白细胞比较低。
And you can see this laboratory result for the complete blood counting with a very low counts of white blood cell.
下面我们可以看到是它的流失细胞数检测的结果，这是在急性白血病里边最重要的一个检测内容。
And also, this slide is about the test result of the flow cytometry, which is the most important techniques of testing used in the AML patient.
从最上行最左侧的一个图 ，CD45 SSE 图上，我们看到红色的一团细胞就是有异常的细胞。
So what you can see on the up left corner here on this SSC A diagram, you can see that the picture showed in red is the abnormal cell that we need to further detect.
这团红色的细胞呢，表达 CD34、CD117。
And you can see that this red colored cell expressed CD34 and CD117.
表达 随系的 CD33，还有异常表达 CD56。
And also we can see that here is another expression of the myeloid CD33 and also the abnormal expression of the CD56.
MPO 反应呈阴性。
And a negative result of the MPO reaction.
没有粒细胞、单核细胞、聚合细胞、幼红细胞的分化表型特征。
And also you can see that we don't have any other further differentiation of the features of the erythrocyte and also the erythroblast or megakaryocytes, etc.
没有淋巴细胞的分化特征。
And also there is no feature of the differentiation of lymphocytes as well.
从这个图上，我们还可以看到，这个红色的细胞聚集一团，没有任何分化的趋势。
And also here you can see that the red color cell is aggregated altogether without any trend of further differentiation.
这是它的骨髓活检结果。
And you can see that this is the result of the bone marrow biopsy.
报告显示，细胞化学、免疫组织化学、MPO 以及溶菌酶也是阴性反应，提示没有粒细胞和单核细胞的分化趋势。
So we can see here is that we can have the negative reaction of MPO and also the cell histological staining and also the others. So here is no kind of a trend of the differentiation of the granulites as well.
也没有 B 淋巴细胞和 T 淋巴细胞的分化趋势。
And also there will be no trend of the differentiation of B cell and T lymphocyte cell.
仅有 CD34、CD117、CD13 和 CD33 的阳性。
And with the immunohistochemistry, we only have the positivity of CD34, CD117, and CD13.
这是它的骨髓形态学结果。
And here what you can see is the bone marrow smearing and also the morphology results.
原始细胞占64%，胞体大小不一，合成圆形或者类圆形。
And here you can see that 64% of the cells are all shown here as the blast, and also these types are in different sizes, round or round-like nuclei.
非常细致的染质以及非常明显的核仁。
And also you can see that this is a very fine chromatin with the nucleus dominance.
没有奥氏小体呈 MPO 呈阴性反应。
And also there is no Aus bodies visible, and MPO reaction was negative.
非性质酶和氟化钠抑制实验也不能证实有单核细胞的分化趋势。
And also for the other kind of test like NAE or NNF, we cannot actually show any kind of a trend of the differentiation of the monocyte.
粒细胞和红细胞数量有限，淋巴细胞数量有限。
And also we have limited number of the granulites and erythrites, and also limited number of the lymphocyte.
结合形态学结果、骨髓图片的形态学结果和骨髓活检以及流失细胞学的形态结果，综合提示这个患者的细胞为髓系来源，但没有明确的粒细胞、单核细胞、幼红细胞、聚合细胞分化方向。
So we can see that if we have the comprehensive cell morphology and flow cytometry result, as well as this smear result, we can see that this type of the cell should be identified as the myeloid origin, but there was no clear differentiation direction into the granulocyte, monocyte, or erythroblast, or megakaryocytes.
在这个时候呢，我们还没有得到它的分子生物学或者分子遗传学的检测结果。
But at that particular time, while we performed those tests, we didn't have the result of the molecular genetics or medical history results or the other tests.
因此，我们提示，如果是分子遗传学以及患者的病史、用药史能排除特殊类型的 AML 后，可以考虑 AML M0。
So that is to say that we should say that if in this molecular genetics or medical history and also the medication history, we can actually rule out some of the AML so that we can know that this is AML M0.
随后，它的分子遗传学结果、融合基因的结果报告出来。
And then after that, we had the report about the molecular genetics and also the fusion gene.
在57个融合基因的检测结果里边，没有阳性反应。
And among 57 fusion gene tests, we didn't have any positivity result.
仅有 WT1 这个泛肿瘤基因有阳性表达。
We only had one positive expression of WT1, such a pan-oncology gene.
基因测序的结果显示，也没有特殊类型 AML 的特征。
And also, the gene sequencing results show that there was no specific characteristics of AML type.
仅有一些与进展和预后有关的阳性基因表达。
And we only had some of the positive gene expression related to some of the positive prognosis.
我们注意右下角这一个与特殊类型诊断有关系的基因都呈阴性反应。
And you can notice that in the item 3, here says that there were no other specific fusion genes or mutation genes that is to say that those kind of specific genes were all negative.
按照 WHO 2016-2017分型的方案。
So you can see that this is a new WHO classification 2016 and 2017.
这个患者的 AML 类型不能归到特殊类型里边。
We cannot actually, according to that classification, include the AML phenotype into the specific type or class.
因此，我们考虑 AML-NOS。
So that is the reason why we consider here this patient should be AML-NOS.
AML-NOS 按照它的细胞类型和发育阶段，那么我们考虑它应该属于 AML with minimal differentiation.
So, and furthermore, with regards to the different cell types and also the stages of the development of the cell, we consider this further as AML associated with M0.
因为下面几种类型都不具备特征。
Because we don't have specificities for the following items.
总结一下这个病例。
Give you a summary of this diagnosis.
它的主要特征是能证明异常细胞是原始髓系细胞，发育阶段比较早期，没有分化方向。
And first, we have to prove that for the abnormal cell, they were primarily speaking myeloid blast without any differentiation trend, and also in the very early stage of the development.
重要的是 MPO 以及奥氏小体呈阴性反应。
And most important thing is that we have to have negative reaction of MPO and also ORS bodies.
没有与疾病类型相关的融合基因或特殊的突变基因表达。
We should not have any fusion gene that is specific to that particular disease or expression, and also we should have no specific gene mutation.
这是我们试验诊断这个病例的一个基础和先决条件。
And this is actually the prerequisite for us to have this particular diagnosis of this patient.
AML M0， 它的主要特征是随系表达，但没有分化方向。
So here you can see that the major features of AML M0 is, first of all, it should be having the myeloid expression without any direction of the further differentiation.
没有淋巴细胞的分化可能。
And also, there should be no possibility for it to be differentiated into lymphocyte.
这是我今天给大家展示的病例，感谢各位聆听。
That is the end of my presentation. Thank you.
Thank you very much. That's all.
Thank you very much, Dr. Yugi. I will shortly comment on your case and on all the work you have done to try any possibility to find some sort of differentiation in this case, which was really these very small cells were really high in the maturation lineage, probably starting their minimal differentiation in myeloid direction. I especially well, this case has been nominated as the thorough and the tough case, and also I would say an exhaustive presentation, which we have possibility to really, like in a textbook, follow as the case has been seen from blood, from peripheral blood with cytopenia, deep cytopenia, and morphology with this small cell fine chromatin, and the flow cytometry, so many markers, so few positives, and histology and immunocytochemistry, and the molecular study, and you have found a few genes, some of which will probably be important in the future, and maybe they will capable of identify new specific leukemias in terms of prognosis. So thank you very much. There will be questions probably, and we will have another Q&A session at the end of the last of this case. So thank you very much again. And the next case is from Russia, from Moscow, the Russian Federation. Dr. Valentina Dvirnik will talk about...
Буду говорить Валентина Дvirnik.
Dvirnik, yes, okay. Case report of acute myeloid leukemia with translocation 821. This case will be commented by Professor Ramon.
Совместно?
Good.
Добрый день, глубоко уважаемые коллеги. Меня зовут Валентина Дvirnik.
Good afternoon, dear colleagues. My name is Valentina.
Я представляю Национальный медицинский исследовательский центр гематологии Российской Федерации и хочу поблагодарить за возможность показать свой клинический случай, который связан с диагностикой острого миелоидного лейкоза с транслокацией 821.
I represent the National Medical Research Center of Hematology of the Ministry of Health of Russian Federation, and I would like to thank everybody to giving me the opportunity to present our clinical case that is associated with the diagnosis of acute myeloid leukemia with translocation of 821.
Одну минуточку.
Just a moment, please.
История заболевания. Молодая женщина 20 лет обратилась в поликлинику с жалобами на слабость, боль в горле, повышение температуры тела, и в анализе крови был выявлен лейкоцитоз до 23 тысяч с бластемией 5%, тромбоцитопенией 20 тысяч микролитров, анемией 97 грамм в литре.
So the history of disease is like this. A young woman of 20 years old had went to the local polyclinics complaining of weakness, sore throat, high body fever, and after the blood works, it was obvious that she had leukocytosis up to 23,000 in microliter with blastemia of 5%, thrombocytopenia of 20,000 in microliter, and anemia of 97 grams in liter.
Она была госпитализирована в стационар, где проводилась заместительная терапия компонентами крови, а затем была переведена в наш центр с направительным диагнозом острый лейкоз.
She was immediately put into the hospital, and there she had received substitution therapy with blood components. And after that, she was transferred to our center for future, for extra analysis in order to get the diagnosis of this type of leukemia.
В нашем центре при исследовании клинического анализа крови был выявлен лейкоцитоз 21 тысяча, бластемия 5%, количество нейтрофилов составило 16 тысяч. Обращала на себя внимание выраженная дисплазия клеток гранулостарного ряда.
So in our center, we had done some clinical blood tests and we had detected neutrophilic leukocytosis, 21,000 in microliter, blastemia of 5%, and the number of neutrophils was up to 16,000. Also, we paid attention to the obvious dysplasia of cells of granulocytic series.
Аномальная сегментация ядра, псевдопельгеровская аномалия, аномальная конденсация хроматина, билобулярные ядра у незрелых гранулоцитов и неравномерная азурофильная зернистость. Также отмечалась вакуализация цитоплазмы.
We had noted abnormal segmentation of nucleus, so-called pseudo-Pelger-Hewitt nuclei, and abnormal condensation of chromatin, as well as bilobular nuclei and immature granulocytes. And we also had seen azurophilic granularity as well as vacuolization of the cytoplasm.
При просмотре аспирата костного мозга отмечалась гиперклеточность, расширение гранулоцитарного ростка с преобладанием незрелых форм, бластоз 6,8%. Часто определялись бинуклеарные промиелоциты, миелоциты, метамиелоциты, также встречались бинуклеарные бластные клетки.
When we had taken the bone marrow aspirate, we had seen hypercellularity, expansion of granulocytic lineage with predominance of immature forms. Also, we had detected blastosis, 6.8%, and we also detected binonuclear promyelocytes, myelocytes, metamyelocytes, as well as binuclear blast cells.
Часть незрелых гранулоцитов содержала гигантские гранулы типа Чидиака Хигаси, нейтрофилы с аномалией Пельгера-Хьюитта или причудливой формы ядра, гипогрануляция цитоплазмы, часто определялись нейтрофилы с гомогенной цитоплазмой лососевого цвета.
Some of the immature granulocytes had contained giant granules of Cheddar-Gigashi type, and neutrophils also were of bizarre nucleus or with pseudo-Pelger-Hewitt nuclei. We also had seen cytoplasmic hypergranulation. Often we had seen mature neutrophils with homogeneous cytoplasm of salmon color.
Здесь также видны гигантские гранулы типа Чидиака Хигаси. Кроме того, присутствовала вакуализация цитоплазмы в отдельных бластных клетках и клетках гранулостарного ряда, включая незрелые и зрелые нейтрофилы.
As you can see on the slide, there are giant pseudo-Cheddar-Gigashi granules that are visible. In addition, you also can see the vacuolization of cytoplasm in individual blast cells and in cells of granulocytic series, which includes immature forms and mature neutrophils.
Эритроидный росток составил 12% без признаков дисплазии. Мегакариоциты не определялись. В частых полях зрения встречались макрофаги с множественными фагоцитированными включениями фагоцитированных клеток.
The erythroid lineage had shown no signs of dysplasia and amounted to 12.4%. We did not detect any megakaryocytes, and they were visible a lot of macrophages with multiple phagocytized cell fragments.
Здесь представлены данные гематологического анализатора. Количество лейкоцитов составило 21 тысяч, гемоглобин 97 грамм в литре, отмечался нейтрофильный лейкоцитоз нейтрофила 16 тысяч, причем в периферической крови определялись преимущественно зрелые нейтрофилы.
And our hematological analyzer had shown the following analysis results. The number of leukocytes was 21,000 per microliter. hemoglobin was 97 grams per liter. The number of platelets was 35,000 per microliter. Neutrophilia was noted, and it amounted to 16,000. And in peripheral blood, they were mainly mature neutrophils.
Справа представлен иммунофенотип бластных клеток. Бластный регион составил 3%. Это были клетки с ранними маркерами, такими как CD34, CD117, и маркерами, ассоциированными с миелоидной линией дифференцировки, такие как 11C, CD13, CD15, CD33.
On the right, you can see the immunophenotype of blast cells. The blast region was 3%. And as you can see, there are cells with early markers as CD34, CD117, and there are markers associated with the myeloid line of differentiation, CD11C, CD13, CD15, CD33.
Бластные клетки также экспрессировали маркеры, ассоциированные с Б-линейной дифференцировкой CD19 и НК-клетками CD56.
We also had seen the markers, the co-expression of markers associated with B lymphocytes as CD19 and CD56, which is associated with NK cells.
Характерная морфологическая картина клеток гранулостарного ряда в отсутствии признаков дисплазии эритроидного ростка, а также характерный иммунофенотип, а именно коэкспрессия CD19 и CD56, позволили предположить у данной пациентки острый миелоидный лейкоз с транслокацией 821.
So this characteristic morphological picture of cells of granulocytic series with absence of signs of dysplasia of erythroid lineage, as well as special characteristic immunophenotype, namely the co-expression of CD19 and 56, had suggested that this patient has acute myeloid leukemia with translocation 821.
При стандартном цитогенетическом исследовании определялся нормальный кариотип 46XX. При фиш-исследовании была выявлена транслокация 821 в 81% ядер, причем определялся один слитный сигнал, два красных и два зеленых, что свидетельствовало о вариантной транслокации с вовлечением 3 хромосом.
So when we had done standard cytogenetic research, we had seen the normal 46XX type. But when we had done the fish research, we had seen the translocation of 821 in 81% of nuclei. So we had seen one fused signal, 2 red and 2 green ones. That is the evidence of the variant of translocation that includes 3 chromosomes. When we had done molecular research, we had...
При молекулярном исследовании был выявлен химерный транскриптор RANX1, RANX1T1, амелето, который составил 1033% по отношению к контрольному гену.
So the molecular research had shown the chimeric transcript of RUNX1, RUNX1T1, which represents AML1-ETO, that amounted to 1033% to the typical control gene.
Таким образом, диагноз острого миелоидного лейкоза с транслокацией 821 был подтвержден, пациентке была проведена стандартная химиотерапия, и в данный момент она находится в полной клинико-гематологической ремиссии на протяжении более 2 лет.
So in this way, the diagnosis of AML with translocation 821 had been confirmed, and the patient had received standard chemotherapy. Recently, she is in full remission, hematological remission, for already 2 years.
Данный клинический случай интересен тем, что был диагностирован при бластозе всего лишь 6,8% и бластемии 5%. Также интересен довольно высокий нейтрофилез, который предполагает возможность созревания некоторых бластных клеток.
So what are the peculiarities of this case? This clinical case is interesting because it was diagnosed with blastosis of only 6.8% and blastemia of 5%. And we also had rather interesting neutrophilia that suggested that some blood cells were still able to maturate. And the characteristic morphology of the cells of granulocytic lineage of peripheral blood and bone marrow and immunophenotype analysis of this variant of disease made it possible to conclude that we have AML with T821.
Особенностью данного случая также явился нормальный кариотип при стандартном цитогенетическом исследовании, наличие вариантной транслокации с вовлечением 3 хромосом, подтвержденным молекулярным методом.
So why this case is so special is because the patient had normal karyotype during the standard cytogenic study, and we had only been able to see the variant translocation in 3 chromosomes by molecular method.
Известно, что острый миелоидный лейкоз транслокации 821 относится к группе так называемых CBF-лейкозов, где мутация в генах приводит к преимуществу опухолевой пролиферации и нарушению дифференцировки гемопоэтических предшественников. Важно, что лейкозы...
It is well known that this acute myeloid leukemia with translocation 8 to 21 belongs to the group of so-called CBF leukemia, in which genetic mutation leads to the prevalence of blast proliferation and the disruption of differentiations of hematopoietic predecessors.
Спасибо за внимание.
So it's very important that leukemias of this group can be diagnosed with the blastosis of less than 20%. That's all so much for my presentation. Thank you so much for your attention.
Okay, thank you so much, Dr. Valentina Divrik. It was a very, very good presentation. Also because you were so clever, because if we see the whole picture, looking the myelodysplastic features, the degranulation, the pseudopelgar, the low percentage of blast, maybe some people will not think in a leukemia because maybe they will think in a myelodysplastic syndrome with blast. But you were so clever, even with a normal karyotype, to do the fission, to do the molecular, and to make this diagnosis. This morphology, as many of the translocation 821 was with maturation, we can see the granulation of the myeloid granulation, and really it was it's normal that they respond very well to the anthracyclines, and the cytarabine and anthracyclines. The thing is, I recommend to all of you also to read an article from the Blood Advances from Sayer Al-Harbi in January 14, 2020, that they make a very nice review, and they present also some natural products like the celastrol from the Tripterigium will 4D from China that are also provoking apoptosis of the blast cells that have this mutation run X1, run H1T1. Thank you so much. It was very interesting, nice morphology, nice photos. We really appreciate your effort. Thank you.
Oh. Okay. We are now proceeding, and the next speaker will be from the Institute of Hematology and Blood Disease Hospital of Chinese Academy of Medical Sciences, Dr. Zhigang Xiao, a case of acute megakaryoblast leukemia. This case has been awarded as a very particular case, and Gina Zini will comment after this. Prepare your questions because we will have a Q&A session after two more cases.
Okay.
Please, Dr. Shao, you can share your screen.
OK，感谢主持人的介绍，很高兴有这样一个机会呢，跟各位形态学专家就形态学方面的知识和内容呢进行交流和探讨。
So first of all, thank you very much for the introduction by the chair. And also, I'm very grateful to this opportunity to have a discussion and exchanges of ideas with all the experts in the morphology area.
那么我今天和大家交流和探讨的题目呢，是一例急性原始聚合细胞白血病的诊断。
And today, what I'm going to talk to you about is a case of a diagnosis of acute megakaryoblastic leukemia.
那么我们知道，急性原始聚合细胞白血病并不是一种非常常见的白血病，它大概占到我们急性随细胞病不到5%。
And we all know that the acute megakaryoblastic leukemia is an uncommon disease, only accounted for less than 5% of the total case of AML.
同时呢，它在成人和儿童都是可以发病的。
While at the same time, it occurs in both adults and also children.
那么在 WHO 造血与淋巴组织肿瘤2017版的书中呢，明确规定了 AMKL 诊断标准。
And also, in this book of 2017 version of WHO classification of tumors and hemopoietic and lymphocyte tissues, it actually regulates the diagnostic standard for MKL.
那么 AMKL 呢，它的诊断标准也是比较简单。首先要求原始细胞要大于20%，也就是要至少达到急性白血病的诊断标准。
So first of all, I think that the diagnostic criteria is very straightforward. First of all, AMKL is an acute leukemia with at least over 20% of the blasts. That is to say, you have to reach the criteria for acute leukemia first.
那么在这些原始细胞中呢，要求我们的聚合细胞要至少超过半数。
And also, among those blasts, we have to meet the criteria that over half are megakaryocyte lineage.
那么诊断 AMKL-NOS 还必须要满足其他3个条件。
And also, we need to meet other 3 criteria at the same time to have this full diagnosis.
那么分别是 AML-MRC 治疗相关性的急性随细胞病以及急性随细胞病伴有重现性遗传学异常。
Those 3 criteria are, first of all, AML with the MRC, and also second, therapy-related AML, and third, AML with the recurrent genetic abnormalities.
那么我们知道，急性原始聚合细胞呢，它的典型形态还是具有一定形态学特征的。
And we all know that there are morphological features of the typical megakaryoblast.
一般情况下，它的胞体呢是中等大小或者是偏大的，一般是在我们的12到18微米左右。
So first of all, the megakaryoblasts are usually, medium to large size with the 12 to 18 micron as the diameter.
同时，它的细胞核比较大，细胞核和胞质的比例呢是比较大的。
And also with a very large nucleoli, with also the nuclear to plasma kind of a ratio is also very big.
它的胞质呈视点性，它的胞质边缘经常呈不规则、有尾足状的凸起。从形态学呢，经常从外形像一只小乌龟一样。
And also you can see that the cytoplasm is basophilic and also often agranular, and also may show a distinct blebs or some of the pseudopods formation like a turtle, as you can see on the right picture.
那么左边这幅图呢，我是为大家展示的一个形态学典型的 AMKL 的骨髓。我们看它的细胞形态还是比较典型的。
And the image on the left is a typical AMKL morphology bone marrow. As you can see from the shape, it is very typical.
但是在我们的实际工作中呢 ，AMKL 它的形态学经常表现为不典型，单纯从我们的细胞形态学很难判定它的来源。
And also, in our clinical practice, in majority of the time, we have atypical AMKL morphology. So if you only talk about the cytomorphology, it's difficult to talk about or to get its origin.
那么我今天呢，就通过分享一例形态学不典型的 AMKL 的诊断，谈一下我们的思路和观点。
And today I'm going to talk to you my thinkings and also my opinions by analyzing an atypical morphology case.
那么这是一个1岁的女性的患儿，主因白细胞增多待查为主诉入院。
And this is a female 1-year-old baby with the admitted to the hospital mainly due to the white blood cell increase.
那我们看她的血常规，她的白细胞是有一个明显的增高，同时伴有比较严重的贫血和血细胞减少和血小板减少。
And also you can see that the blood routine shows a very highly elevated white blood cell and also very little bit anemia as well as the reduced number of platelet counts.
那我们看一下她的骨髓，在低倍镜下呢，她的骨髓呈一个明显的增生极度活跃。
And also you can see that here we have shown here on the bone marrow, which is to say that here is a super active hyperplasia.
同时，原始细胞异常增殖，原始细胞的比例是非常高的。单纯从我们的细胞形态，可能很难判定这些细胞的系别。
And also, you know that the ratio and percentage of the blast is very, very high. So if we are only talking about the morphology, it's difficult to talk about its lineage.
那我们做了 MPO 的染色，它的 MPO 的染色，也就是髓管化酶是全阴的。
And we did the MPO staining with full negative result.
PAS 染色是阳性，那么阳性物的酶型呢是粗颗粒和比较强的珠状。
And you can see that we also did the PAS with a positive result, but you can see that the shape is a coarse kind of a shape with the bead shape as well.
那么我们又完善了其他的实验室的相关检查，它的染色体核性分析46条染色体都是正常的。
And also we did other tests in the laboratory. First of all, the karyotype, 46 of them are all normal.
它的分子生物学，我们检测了 B3ABL、M1-ETO、PM2 等43种常见的白血病融合基因，都是阴性的。
And then also, in terms of the molecular biology, we have tested 43 common leukemia fusion genes, such as the BCR-ABL, ML1-ETO, etc. They're all negative.
它的分子生物学异常的原始细胞大概占到有核细胞的90%左右。
And also, for the immunophenotyping, we have seen that the abnormal cell population accounted for over 90% of the karyocytes.
那么这一群细胞呢，强表达 CD34、CD117 等早期的随系标记，同时还表达 CD56和 CD33。
And also, we can see there is a strong expression of CD34 and CD117, such kind of myeloid expression, and also CD56 and CD33.
那么它表达 CD23， 弱表达 CD13和 CD19。
And also with the expression of CD123 and also the weak expression of CD13 and also CD19.
它不表达 MPO 以及 CD7、CD10、TDT、包浆 CD3、CD79A 等等邻系的标志和我们的 MPO。
And also you can see that there is no expression of CD45 and MPO or CD7, CD10, TDT, CCD3, those kind of lymphoid lineage expression.
同时呢，我们发现一个非常有意思的现象，这群细胞不表达 CD45。那我们知道，我们的血细胞里不表达 CD45 的细胞是非常少的。
And also, a very interesting phenomenon here is that there is also no expression of CD45. But also, we know that in the cytoplasm, and actually there is a very, very little cell that doesn't have expression of CD45.
那我们比较常见的血系统疾病不表达 CD45 呢，以及血系统相关的疾病，主要包括以下几种。
So if we think about the negative expression of CD45, we may consider the possible hematological diseases.
它们分别是纯红白血病、浆细胞肿瘤、转移瘤以及 AMKL。
So there are pure erythroid leukemia or plasma cell neoplasm or metastatic tumor or AMKL.
我们首先从形态学简单的做一个判定。那我们的纯红白血病呢，是以原始红和早幼红增多为主。
And also, first of all, we are going to have such kind of judgment. First of all, on the morphology. If we are talking about the pure erythroid leukemia, normally speaking, we have those kind of erythrocyte cell increasing, or the number of the erythroblasts are increasing.
那么原始红细胞呢，胞质一般是呈比较强的嗜碱性，同时会伴有各种发育异常。
And also we can see that for the cytoplasm, there is a very high basophilic for the erythrocyte blast, and also we're going to have the abnormal development of the cell.
那么浆细胞呢，从形态学来讲还是比较容易辨认的，它的胞质也是嗜碱性比较强，胞核经常会有明显的核偏位。
And also you can see that here is a very clear diagnosis or clear observation of the plasma cell with a very basophilic cytoplasm and also the mislocation of this nucleoli.
尽管我们的骨髓转移瘤有的时候可以单个细胞散在分布，但是大多数转移瘤在骨髓里是聚集分布的，同时它的细胞形态呢，跟我们的血细胞也不一样。
And also, you can see that talking about the metastatic tumor, sometimes the cells can be quite scattered, but in majority of the cases, those cells are aggregated, and also the morphology is very much different from the hematological cells.
所以说，通过细胞形态学的初步判定，我们认为这3种疾病的可能性都不是很大。
So from the initial round of the morphological kind of a judgment, we don't think, or we think that there is a very little possibilities for these 3 types of diseases.
那么最后我们把目光聚焦到了 AMKL 上边。那我们知道 AMKL 一个相对比较特异性的检查就是 CD41的聚合酶胞染色。
And also, then we are going to laser focus on AMKL then. So we know that a very big feature of the AMKL diagnosis is CD41 megakaryocyte enzyme staining.
那我们做了 CD41 聚合酶染色之后，这些细胞绝大部分都是强阳性的。
And with such kind of a staining, we found majority of the cells are high positive.
那么这个时候，我们高度怀疑这个患者有可能是 AMKL。
So we really are very suspicious that the patient should be AMKL patient.
那么我们为了验证 CD41 聚合酶胞染色的准确性，我们又在免疫表型上加做了 CD41 和 CD61 的抗体，并且都是表达的。
And also, in order to make sure that this is a correct conclusion, we also made a further immunophenotyping so that we can see that CD41 and CD61 are both expressed.
那么这个病人呢，到此他的诊断是比较清晰了。我们考虑一个 AMKL NOS。
So now we can have the final diagnosis. That is to say, this patient is AMKL NOS.
那么通过这个病例，我们可以发现呢，很多急性白血病它的形态学特征是不典型的。我们现在诊断急性白血病更多的是依靠 MICM 的综合诊断。
So you can see that now with such kind of a case analysis, we know that for majority of the acute leukemia, some of the morphology is atypical. So we have to have such kind of a comprehensive diagnosis using MIMC.
单纯靠我们的细胞形态学诊断急性白血病具有一定的局限性。
And also it's very much limited if we only rely on morphology as a diagnostic feature or standard.
我们尽可能的结合形态学、我们的病史、临床表现以及 MICM 综合的判定。
So we should try our best to comprehensively take into consideration all the 3 factors: morphology, medical history, and MICM.
只有我们做到精准的诊断，才能做到精准治疗。
So the prerequisite for the precise treatment should be precise diagnosis.
那么好，今天的病例呢，就跟大家分享到这里，感谢聆听。
So much for my case sharing. Thank you for your attention.
Thank you very much. Is there a comment by Professor Gina now?
The case was very beautiful, well illustrated, and well studied. And it's when we do not have at the microscope positive data such as cytochemistry, the flow is mandatory. And in your three beautiful images comparing the differential diagnosis among erythroid, plasma cell, solid cancer, with morphology also in these entities where there are not positive data, it's very well, it's notable to appreciate the details of morphology of the cells that can orient the diagnosis. In the cancer cell, those blue inclusion, very, very beautiful images. Thank you.
Okay, so thank you very much, Dr. Xiao, and your case has been awarded as a very interesting case. And the next and last presentation is by Dr. Cristian Lopez. I'm going to share my screen, and it's a case of acute myeloid biphenotypic leukemia from Ecuador, Fuerzas Armadas. Please, Dr. Lopez, share your screen and start your presentation.
Muy buenos días con todos. Para mí es un honor estar en esta presentación junto a ustedes.
Good morning to everyone. It's my pleasure to get the meeting.
Agradezco mucho a la doctora Cini, al doctor López y al doctor Onofrio que nos han dado la oportunidad de exponer estos casos.
Thank you very much for Dr. Gini and Dr. Lopez and Dr. Jin to invite me for the seminar.
El caso que les voy a presentar se trata de una leucemia mieloide aguda bifenotípica.
I will share with you with the phenolic acute myeloid leukemia.
Bueno, se trata de un paciente masculino de 74 años con algunos antecedentes que los procedo a detallar a continuación.
It's about the case is 64 years old, is a male patient with a history of the peripheral cerebral cancer in 2013.
Entre los antecedentes del paciente tenemos un cáncer tiroideo papilar, también tenemos un cáncer de próstata y también tenemos diverticulosis y gastritis crónica con Helicobacter pylori.
In the medical history, he had some plus central empties, prostate cancers, and tuberculosis, chromocrastis.
Excuse me, Dr.
Esto
Lopez.
nos hace ver que el
Dr. Lopez, can you hear me? Can you open your presentation to show the slides?
Sí se notan los slides.
PowerPoint.
Doctor López, usted tiene que compartir y al momento de compartir tiene que elegir la presentación. Por si no comparte su screen, pero tiene que compartir específicamente esa presentación.
不好意思，现在演讲者的视频没有分享，等一下他。
Good. Bueno.
Ahí está bien.
可以看得到，大家可以看到吗？
Ya. El motivo de consulta del paciente fue una fiebre y sangrado nasal.
A reason for the consultants is it has a fever and epistaxis.
El paciente refirió que desde hace 3 semanas presentó astenia, malestar general, pérdida de peso y fiebre de causa desconocida.
The patient reports that for almost 3 weeks, he has present asthenia, general malaise, uncurred weight loss, fever without no apparent cause, and epistaxis.
En estas láminas nosotros vamos a ver los hallazgos que tenemos en sangre periférica.
In these results of laboratories, we can see very clearly about the peripheral blood.
Nosotros podemos observar que tenemos algunos linajes morfológicos en las presentaciones. Por ejemplo, en la diapositiva de la izquierda observamos una célula grande con núcleo grande y con citoplasma gris azulado.
We can see clearly in the picture that the plus is very big and nearby it has some plus angularly.
También podemos observar en la parte intermedia una célula con bastantes gránulos, que serían blastos granulares.
In the middle picture, we can see clearly the blast is angularly, and we can see also about the nuclear is very clear.
Y finalmente, en el extremo derecho, vamos a observar blastos sin gránulos, que serían blastos agranulares.
In the third picture, we can see clearly about the blast that is without the nuclear, we say is blast angular.
Algo que nos llamó la atención de este caso es la figura que ustedes tienen en el centro, en el intermedio, esas prolongaciones de una célula blástica agranular.
We can see clearly in the middle incorporation, this is a plus granularis.
Ustedes pueden observar el pleomorfismo, la diferencia de tamaño y de morfología de las células que se presentó en este paciente.
We can see clearly after comparison, we can see the right intrinsic staining in the size and also for the shapes.
Por ejemplo, en la imagen de la izquierda podemos ver un blasto granular cuyos gránulos tienen mieloperoxidasa, hidrolasa, fosfatasa ácida.
We can see clearly for the side pictures, there are the plus granulary and agunary.
En la imagen del centro podemos observar blastos con un nucleolo gigante, un nucleolo grande, muy posiblemente de serie mieloide, mínimamente diferenciado.
We can see in the middle, for the blood pictures, the nucleoli is very big. It's nearby is also some angular plaques.
Estos detalles son de médula ósea. Ahí obviamente podemos ver la presencia de hiato leucémico, es decir, la presencia solo de las células precursoras y de las células maduras.
From this picture, we can see clearly the plaques in bone marrow is mature and grows big one.
En esta diapositiva, en la parte izquierda, podemos observar un blasto monocitoideo con vacuolas junto a otros blastos vacuolados.
From the right picture, we can see clearly the plexus after the diagnostic. From the laboratory is like the foci-chromatic follicle spreads and the plexus angulary.
En la parte derecha observamos el núcleo de un macrófago porque el paciente estaba teniendo fagocitosis, hemofagocitosis.
And we can also see clearly nearby it has a nuclear that because the patient has some microphages.
En esta diapositiva podemos observar blastos grandes agranulares de citoplasma celeste cromatina laxa, muy posiblemente linfoblastos, que lo descartaríamos con citometría de flujo.
We can see also in the right one, they have a big large angularly. That means this has been in long side, and after a long time, it has grown into some angular size.
En esta lámina, en cambio, vemos la coexistencia tanto de blastos con gránulos como de blastos sin gránulos.
We can also see the plasmas with and without nucleus. It means it's a granulary and angularly blast.
Y aquí observamos también otras pocas células como promielocito en la parte derecha dentro de una isla de blastos.
We can see in the picture have very few ciliary promorphites in bone marrows.
Observamos también precursores eosinófilos en poca cantidad, como en la imagen izquierda.
We can find the plastics very few in the metaphoricities.
Muy bien. Con esta sospecha diagnóstica nosotros vemos la biometría hemática que tiene una cantidad de leucocitos extremadamente alta, 159,000 leucocitos.
From this picture, we can see very highly about the WPC is very high. It's nearby to 159.
Algo que nos llama la atención es que el contador hematológico no nos da las series de las estirpes ni linfoide, ni monocitoide, ni neutrofílica, como ustedes pueden observar.
That means the anoprin cannot cause our attention to the lysorgy and the blasting that you can know to the results.
Lo único que tenemos es una basofilia de 770. Generalmente las basofilias nos dan una orientación a serie mieloide.
The only one cause our attention is about the PAS1. The PAS1 is very low than our normality values.
Algo importante es que el paciente tiene anemia con hemoglobina de 9 y trombocitopenia con plaquetas de 14,000.
It's very important to inform us this patient has pneumos that he caused the agent ones.
Esto quiere decir que estas células que observamos que son blastos están desplazando tanto a la serie roja como a la serie de plaquetas.
That means it has the plus white one and the red one.
Aquí tenemos los dispersogramas en el que observamos en el canal DIF esta población en blanco gigante.
From this picture, from the results laboratory, we can see from the DIF pictures is very big, the white is very big and it grows more large.
Algo muy importante de considerar es que cuando ustedes tengan una población en blanco, significa que el contador hematológico no puede identificar las células. Por ejemplo, aquí no sabe realmente cuáles son linfos, cuáles son neutrófilos, cuáles son monocitos.
It means it's very difficult to recognize about the lymphocytes and the lymphocytes.
La imagen roja, la población que nosotros tenemos en verde y en rosa.
不好意思，刚才他讲话听不清楚。 Por favor, no escucha bien tus palabras. ¿Puedes
Aquí
repetir?
vemos una imagen en 3 dimensiones de la población.
This is the 3D images we can see from the color green, color red, and the blue one.
Nosotros podemos con esto deducir que aquellas células que el contador hematológico no identifica se tratan de blastos.
We can make sure that this can lower the blasts in the blood.
Esta es una lámina en donde nos muestran las alarmas que el contador hematológico nos da.
Here is some laboratory results about the blasts that we can show clearly from the results different one.
Y en esta imagen nosotros podemos ver también qué alarmas nos da el contador hematológico, tanto de blastos como de linfos atípicos, de linfos anómalos, que algo nosotros confirmamos ya en el frotis de sangre periférica y médula ósea.
In this picture, we can show very clearly about MAL, which shows about the features of monocytes and linearicities.
Y este es el reporte de sangre periférica que nosotros hicimos, ¿no? En el que detallamos 4 poblaciones importantes.
Here is about the peripheral blood forest report. We have 4 groups.
La primera población en 26% son de blastos agranulares.
The first group is about 26% is about the angular group.
La segunda población en 15% son de blastos vacuolados.
The second one is 15% is about the large blasts.
La tercera población en 10% son de blastos con gránulos.
The 10% is about the blasts with nucleus.
Y la cuarta población son de blastos agranulares con nucleolos gigantes.
The last one, the first one is about 50% is about the high nuclear angular blasts.
Con esta sospecha diagnóstica, nosotros podemos pensar que hay muchas estirpes celulares, por lo cual pensamos en una leucemia bifenotípica.
From these features, we can make sure about the leukemia manuspathis. We can see clearly from the cellulars and to have a diagnostic clearly.
Por ello, nosotros mandamos a realizar algunas translocaciones como las que podemos observar, la 821, AML1-ETO, la inversión del cromosoma 16, CBFB, MYH11 y la translocación 922, ABLBCR, que es el cromosoma Filadelfia.
It's very common to perform about the test from 821, AML1, ETO, and also with INV 60, CBFB, and from 9 to 21 for some amorphous diagnostic.
Aquí observamos los exámenes de laboratorio del paciente en donde llama la atención una cantidad alta, elevada de la LDH porque es una oxirreductasa.
Also from the laboratory test shows very high in the LDH1.
A más de eso tenemos elevada la beta-2 microglobulina en 6.4 y también una elevación del perfil hepático.
Also means very high in the beta-2 and also in the GGT.
El dímero D se encuentra elevado porque había ya también afectación a nivel de tromboembolia pulmonar.
It means very high affected about the morphologies.
En esta lámina podemos observar los resultados de citometría de flujo.
In this laboratory result shows about the flows and similarity.
Primero observamos el CD34 está en 84%, quiere decir que es un proceso agudo.
We can see the CD34 is very high, it's almost about 18.5%.
En cuanto a la serie mieloide, tenemos elevado el CD33 y también el CD117 fuertemente.
For the Morphology series in Morphis, we can see clearly about the CD33 and the CD117.
En cuanto a la serie B, tenemos muy elevado el CD19.
In the group of series B, we can see very high is the CD19.
En cuanto a la serie T, no tenemos expresiones altas de los inmunofenotipos.
When we in the series D, we can see not very high about the immunologies.
En la serie de monocitos tenemos elevado el CD14 en 68,32%.
And about the monocyte series, we can see very high, the CD40 is almost 68%.
Esto nos lleva a pensar algo, que existe una elevación tanto de componente mieloide, componente linfoide, como componente monocitoide.
This cause our consideration is very high to avail from the monocytic features.
Llama mucho la atención que de las estirpes celulares, la más elevada está a nivel de serie B con el CD19 en 85,23%.
That means the treatment in the case of leukemia, it can use about some indicators which is over than 32%.
Cuando nosotros realizamos los estudios cromosómicos y la secuencia molecular, podemos observar el siguiente resultado.
From these laboratories, we can also take some in consideration of the report analysis of the chromosome and also the report test of the molecular.
A nivel cromosómico y a nivel molecular, lo positivo de este paciente fue una translocación 922, secuencia molecular ABL-BCR.
It means this patient is from the chromosome translations, from translation cases from the 9 to 22 dedicated.
Es importante mencionar que esto es el cromosoma Filadelfia con la glicoproteína 190.
It also means the percentage is like about 119.
Aquí observamos una tomografía de cuello y una tomografía de tórax.
Here is about some results from the neck tomographers.
En el cuello observamos nódulos de 9 a 13 milímetros.
This one we can see nodules from 90 millimeters to 30 to mm.
Y en el tórax observamos nódulos o ganglios a nivel pretraquial, especialmente de 16 milímetros.
And we can also see some rounded appearance. It almost reached to 60 mm.
Aquí tenemos una tomografía de abdomen.
Here is some result from abdomen.
Aquí observamos hepatomegalia y también presencia de nódulos linfáticos.
We can see clearly from the optometrist there have some enlarged lymph nodes.
Esto significa que el comprometimiento del paciente fue a nivel sistémico. Estuvo ya el comprometimiento a todo nivel orgánico.
It means this patient is very critical, is a very organic patient.
Para concluir, nuestra conclusión fue que este paciente tuvo una leucostasis por hiperleucocitosis compatible con una leucemia aguda bifenotípica.
I make a conclusion that means leukostasis due to hyperleukocytosis compatible with acute leukemia.
Esta leucemia tenía componente mielomonoblástico y también componente linfoide.
In the diastico, we can see in the context that has some myelomonoplastic and also have lymphoid.
Como ustedes recordarán, la primera población era agranular y tuvo una expresión del CD19 en 85%.
We can see in the first group or in the first series, there is a very high express of CD19, can reach to 85%.
La segunda, vacuolares y también blastos granulares.
A second population of the minority leaders can have some large blasts and also have with the angular express.
Nuevamente es importante mencionar que de estas poblaciones, la más alta, la hiperexpresada, era a expensas de ser el linfoide, con el CD19.
It has a very high express of CD19.
Al paciente se le trató de realizar citorreducción con leucoféresis para intentar una inducción de quimioterapia.
We have some medical technologies use the central nucleus to lower the high express.
Lamentablemente, el pronóstico del paciente, como pueden ver, fue malo y el paciente lamentablemente falleció.
We are very sorry. After this treatment, the patient is died.
Dentro de la clasificación de OMS podemos ver nuestra positividad con ABL-BCR en esta parte de aquí.
We know in the classification of the WHO, we use the AML and also we use the wrapper in this classification.
Para mí ha sido un placer saludarles desde Ecuador. Aquí en América admiramos mucho toda la labor que se encuentran realizando ustedes.
It's our honor to join our meeting from Ecuador. We very appreciate your work to share your experience and with this chat. Thank you so much.
Les mandamos un saludo desde el otro lado del mundo. Muchas gracias.
Greeting from the other side of the earth. Thank you to all.
Thank you, Dr. Lopez. And I think Professor Ramon Simon is there for a comment on your very interesting case.
Yes, this case is really very interesting because I am sure in the question and answers will be a lot of questions for this case. Yes, finally, we have a very beautiful documented case of mixed phenotype acute leukemia, MPAL, with translocation 922Q34 BCR Abelson 1 positive. And the thing is, yeah, the basophilia, the presence of lymphoid blast that is also frequent in the blast crisis of the chronic myeloid leukemia, that will make very nice discussion after this presentation. Really, thank you for your effort and for your for the award you have received for being one of the best cases for this HemaTalk. Thank you so much, Dr. López. Muchas gracias, Dr. Cristian López.
So thank you very much, Professor Ramon Simon. And now we go on with a few questions. We have received one question. Well, has already been answered on the chat, but I think that we can share with everybody. Dr. Putri has a question from Dr. Sohail Ahmed and asked which genes connect DS to AML. And is there, Dr. Putri, are you there? Well, she has a written answer anyway, and which is the somatic mutation itself increased leukemiogenesis, and GATA1 mutation is the most found in MLDS. Another mutation is JAK123, MPL, RAS, found in 56% of cases. And unfortunately, they could not perform GATA1 in their cases. Then I have there's a question to Dr. Xiao.
Giuseppe, hai la voce interrotta.